So for people who've just joined the recording, this is my first slide, and we're looking at activities of daily living rehabilitation. So this information tells us a little bit about the time use of older people who are mostly retired, but people who don't have a diagnosis of dementia. And we can see that they spend a large proportion of their waking hours in leisure activities by themselves, or instrumental activities of daily living, so activities like cleaning or shopping, social leisure activities, so leisure activities with other people, and then BADL, which is basic activities of daily living like showering, dressing and eating, and then a small proportion in transport. So the day is pretty full of activities. Our next slide just shows us, seems to be a bit of a lag with my slides. Here we go. So this work was done with people who live in residential care with a diagnosis of dementia. And you can see that one of the main things people said was, I'm dying of boredom. So of the working day, these people who had dementia in a residential care facility spent almost 9 hours doing absolutely nothing. So just sitting, really. They spent the next largest amount of time was participating in eating or drinking, so almost 2 hours, and I'm sure not all of that time was actually ingesting food, but sitting in that environment, eating or drinking. Participation in all other activities was just over an hour, and participation in activities of daily living, so that's dressing, showering, grooming, any toileting, was only 12 minutes a day. So we can see that there's a really stark contrast between older people in the community without dementia and people with dementia in residential care facilities. On a special care unit for people with dementia, again, we can see that most of this time, so that light blue, the biggest chunk of time, was spent with background media. So really that was time spent either watching the TV or listening to a radio. The orange component, the next biggest time, was considered downtime. The grey part, was actually watching the TV. The blue part was that they were sitting and there was a TV on in the background, but it wasn't necessarily a chosen program, or a radio, but it wasn't necessarily focused on what they wanted to do. The grey part was they were watching something on TV that was in line with their interests. And then mealtime, activity groups and ADLs a very small chunk of the time as well. So you can see that people are relatively inactive and disengaged, which is, terrible. When one of my colleagues, Rachel Milty, looked at what were the main contributors to quality of life in people with dementia and residential care, and these were the main themes that they found. So this was the result of their interview. One was that they really valued choice, freedom and self-determination, and that's really difficult in a residential care setting, but there's certainly ways that we can make that happen for people, and there has been some discussion in Australia about having a consumer-directed model of care in residential care and what that might look like. The second was it was really important to have meaningful activities. So people said, I've still got hands and I want to be able to use them. Another part was feeling useful and valued. Again, that can be really difficult, and our traditional residential care models aren't really set up to promote feeling valued and useful, but we certainly can make that happen. And the final was respect for possessions and personal space. Again, difficult, but these are things that are so important to quality of life. So these are the things that we should be looking at. And I know it's tricky because currently in residential care in Australia, for example, we have a focus on things like, preventing pressure sores, or, limiting too many unnecessary medications. So these are very medical focus things, but actually what really matters to quality of life are these types of things. And I'm sure that's no surprise to anyone on this call. Now, our next graph shows patterns of functional decline in people with dementia. So we can see here, so the top left here, we've got around memory complaints. So the darker blue purple line is people without dementia, and the red is people with dementia. So we can see over time the amount of memory complaints in the person with dementia increases to the point of diagnosis. The next is the MMSE again. So this is, I guess, a little bit different to the memory in that it's a kind of a different pattern in that there's this real drop off, and that probably is triggering this seeking of a dementia diagnosis. On the bottom left, we have instrumental activities of daily living. Again, we see that in the time leading up to diagnosis, so particularly that year prior to diagnosis, there's a significant drop in the person's ability to do instrumental activities of daily living, like cleaning and shopping. But we can see basic activities of daily living don't vary that much in the time leading up till diagnosis. So people remain pretty independent in terms of their everyday type activities, grooming, dressing, bathing, those types of things. One of the main things we know is that humans have a need to do, and what I guess what we want to avoid, particularly for health professionals and for family members, is we want to involve in starting and moving around this cycle. So we can see as someone starts to have a reduction in their physical and cognitive ability due to the symptoms of dementia, then other people feel like they're doing the right thing by taking on their person's usual role. So they'll feel like they're helping when they do the garden, or they'll pop over with shopping, or they'll go over and do the things that would have been done by the person, which leads to a cycle of the person becoming less active and engaged in activities, and then a subsequent further reduction in physical and cognitive ability. So people have very good intentions, but we really need to be careful that, you know, if we're helping with, maybe we're doing things together, or we're spending our time providing social support or doing other types of things, because we really don't want to take away those key activities and roles and leave the person with nothing to do. And we can see in Maslow's hierarchy of needs, so, you know, we all know that our basic needs are food, water, warmth, rest, security and safety. We then need for our psychological needs being friendship and feelings of accomplishment. But then, of course, the highest level of needs, and this is what we really should be aiming for in our work, is particularly when people have quite mild symptoms, is around self-actualization, so achieving one's full potential, including creative activities. So when we, you know, kind of focus very much on very basic things, we sometimes neglect these things that are most important and provide self-fulfillment. So I wanted to provide a couple of examples. So Ted lives alone. He has mild dementia symptoms. He's beginning to have difficulty preparing meals. So we might think, you know, I'm worried about Ted. I'm worried that he's not feeding himself. I'll organise a meal delivery service for him. So this would be what we would call the dependency approach, where we're doing for the person. However, a rehabilitation approach, or doing with the person, would include perhaps involving family or friends. They might come over and prepare meals together. They might come over and join Ted for meals so that he cooks for both people, and to make it a social occasion as well. They might, or his family and friends might provide help with shopping and storing food items safely. They might develop a routine meal plan, which takes some of the complexity around planning for the week, a shopping list to support that meal plan. They might put together a booklet of simple recipes, so there's kind of a go-to place for working out what Ted will be eating ahead of time, clearly labelling items, and then having some safety mechanisms if we're really concerned about safety, like a smoke alarm. So we can see here what is what we would usually do. There's a lot of strategies in terms of rehabilitation that we can do, and these help promote that self-fulfillment and independence. There's a number of different tools to assess activities of daily living in people with dementia. So this slide I kind of mostly include for health professionals who might be interested in using a measurement tool. So the Bartell is one of the most common. And the CATS, Index of Independence in Activities of Daily Living, are probably the most common, but all those other tools are quite useful as well. And then activity analysis is also commonly used as a way of assessing the person performing an actual task and working out where the breakdown in the task is. So are they having trouble starting the task? Are they having trouble finding the objects? Are they having trouble when they have to do two things at the same time? So just by watching someone, we can get an idea of what issues they're struggling with and then how we can support that. Now, this is a forest plot. So this is a graph which shows us the relative benefits of different non-pharmacological treatments for people with dementia. So the outcome of interest here is activities of daily living. So we've got a number of different interventions listed here. So we've got exercise, dyadic interventions, psychological treatments, case management, music therapy, cognitive stimulation therapy, and cognitive training. So any of these particular interventions where the blue diamond is to the right of the dotted line means that they're considered to be significantly beneficial. So we can see that the best thing that you can do to maintain independence in activities of daily living is to exercise. So we can see that that's clearly the most effective way. The second is dyadic interventions. So when I say dyadic interventions, that's often considered to be working with the person with their family and the person with dementia to identify care challenges and to problem solve that through using rehabilitation strategies. So like I said before, that example with TED and the meal preparation, that would be something that you'd work on in a dyadic intervention. So coming up with strategies to address care challenges. And the other one that we can see is relatively beneficial here, a bit further down, is cognitive stimulation therapy. So if we want people to stay independent in activities of daily living, exercise, dyadic intervention, and cognitive stimulation therapy are the most important things that we can offer. Now, I should say we did compare this to some of the acetylcholinesterase inhibitors. Now we know, like Aricept, for example, now we know as well that they are also effective. So they do delay decline in activities of daily living function. However, the effect size is not as significant as exercise and dyadic intervention. So they are beneficial, but not to as much extent. So really we can see the power of non-pharmacological interventions here. So dyadic interventions, as I explained, they're extremely beneficial. It involves collaborating with the person and their care partners, prioritising care challenges and rehabilitation goals, focusing on the person's strengths and capabilities. And then, as I said, we're looking at task activity analysis and then adaptation. And we might also use strategies of environmental modification and communication simplification. So dyadic interventions, they have mostly been tested in people with mild to moderate symptoms of dementia. They really haven't been tested in people with more severe symptoms or people in nursing homes. They usually require multiple consultations. So one of the tricky things about health services, particularly, I'm talking about the Australian experience here, is that usually people will only be funded to see a health professional maybe a couple of times. And that might be for assessment and advice. However, we know that with these types of programs, you're really wanting to see someone between about 5 and 10 times so that you can really understand what's going on for them, what their values are, their priorities, get to know them, and to work with strategies, because we know that some strategies won't work. So we need to work out what will work and to be able to refine them over the time. We do also know, of course, that this isn't kind of something that you do once and then that was it, because we know that people's strengths, capabilities, symptoms and care challenges change over time. So there will be various times after diagnosis that we need to step in and offer these interventions to get the most benefit. And as I said, most really relates to work in community settings. There's only been a couple of trials in residential care settings, and so far they haven't had the same level of effect. Which doesn't mean that they don't work, there's just really hasn't been enough done in that area to examine that. So an example of activity adaptation, so Jane lives with her daughter, she has difficulty dressing herself independent. So some of the strategies that you might use in a dyadic intervention is to talk with Jane's daughter about why this might be happening. So maybe it's because she's having trouble seeing what the different clothing options are available to her. Maybe she, needs some labels on the closet to remind her where things are stored. So you'd also educate her around why staying independent was important, because it's quite tempting for Jane to step in and just help her mum. But as I said, then we feed into this cycle of dependency. So Jane may place out the required items, limit choices, have a routine, so dressing always in the same place at the same time, and just doing one step at a time. So, for example, passing one item of clothing and then allowing time before getting out the next, because having everything set out and also that choice making adds to the complexity. But we can still support Jane to be able to dress herself independently with some of these supportive strategies. So an example of environmental modification that you might use in a dyadic intervention. So John likes having his neighbour over a chat and making him a cup of tea. So, you know, as his neighbour starts to see John struggle with this, the temptation is to step in and take over and make them both a cup of tea. However, really the neighbour could best support John by using some of these strategies. So perhaps helping John put things out on the bench. Someone could help John remove clutter so that only the things that he needed were in immediate view, reducing other distractions, so turning off any background TV or music, spending the time sitting in a comfortable environment with good lighting and a comfortable temperature, so it's a very, you know, all-round kind of pleasant experience. And then focus just on making the tea and then the chat, not both at the same time, because we know this dual tasking is particularly challenging for people. It, you know, users, it requires more cognitive skill to do that. So I just wanted, my last few slides are around, you know, when I started out as an OT in 2003, I think my first job was in a hospital. We were really at the stage where we were, you know, we had big orientation boards and clocks, and we had, you know, we'd organise for a cleaner to go in, but there's so many devices now which really support independence. So having a smartwatch instead of a personal coal bell or personal coal pendant. There are devices which kind of turn off the kettle when they're needed. Instead of having a cleaner come in all the time and vacuum, you can look at a robotic vacuum. So we just have so many more options. And I think sometimes, you know, we need to remind ourselves of all these things that we can use, which are actually great at supporting our independence without kind of that need to look at health devices as such. Because let's face it, you know, often they're more expensive, and, you know, people don't always like the look of them. Here's another example. So these little tiles are really handy. You can put them on different devices. You can put them on your keys so that you can help find your keys. So they're really good for tracking the location of things that might get lost often. And, you know, things like regulating hot water temperature. So these are really good as well for family members who are worried about the person, you know, cooking or getting burnt by hot water. There are some of these things that we can put in just to help support or just prevent any accidents. So the other thing I just wanted to share, so this is some things I've been looking at recently. I had a really interesting workshop with older people talking about future planning their homes. And there's some really interesting work coming out of different places around the world. And there's this one concept, there's basically new ways of thinking. So our previous way of thinking was, you know, we make everything in the house super easy. So we get rid of steps, we put in ramps, we put in grab rails, we really remove any level of challenge from the house. But, you know, some people are starting to think, well, actually, if we really want to support independence and function, we should be building houses to challenge people. So you can see here, now these aren't real houses. These are kind of for display purposes. They're designed to be provocative, really. But, you know, should we be designing houses in a way that makes people work? So we can see here there's a sunken kitchen, there's steps, there's uneven surfaces, there's things to hang on to and climb. So I think, you know, this is pretty out there, but this is a really interesting way to think about the future. And instead of simplifying our houses, how do we build them up to be facilities which help us stay independent and active? Again, you know, even, you know, the past and probably the present to much extent is still around, you know, putting in handrails, but we can see that people are becoming increasingly interested in inclusive design and universal access. So we can see, you know, the use of bidets, for example, and smart toilets is becoming more widely used. And on the right, we have this sink, which has a handrail integrated, but it's integrated as a design feature. So people can, you know, hold on to that for support while they're washing their hands. But we're looking at ways which we can make this be something that everyone can use, rather than being kind of a feature for those who need it as such. So I think, you know, we're really progressing in terms of design, and there's some great products which are becoming available. So that's the conclusion of my slides. I'll stop sharing and I'll hand over to Claire.
So before I get started, I just would like to introduce myself. I'm Claire, I live in Sydney. I'm an occupational therapist as well, as Kate mentioned. But I'd just like to acknowledge the traditional owners of the land on which I'm sitting today, the Dyadic and the Eora people. I'd like to pay my respects to the elders past, present and emerging, and extend that respect to any other Aboriginal and Torres Strait Islander people who may be watching today. I would also just like to mention that I have a puppy in the house at the moment, so I'm really sorry if you hear her barking while I'm talking. Okay. So for people living with dementia, as it is for all people, engaging in regular leisure activities is an important part of life that helps maintain a sense of self and well-being. Participating in leisure activities provides an important opportunity to focus on a person's abilities, reduce social isolation, and to foster positive experiences. When people living with dementia experience difficulty in accessing or participating in leisure activities, they're more likely to experience behaviour changes and subsequent impacts on quality of life. Therefore, supporting a person to participate in leisure is so important for improving a person's well-being and quality of life. Participating in leisure can even be therapeutic by reducing behaviour changes, improving sleep, and delaying decline in everyday functioning. Emerging research is showing that there are interventions that can support a person living with dementia to remain engaged or re-engage in enjoyable activities. For example, activities can be tailored specifically to a person's interests and abilities, and their care partners can be taught strategies to support the person with dementia to participate in these preferred activities. And these strategies have shown positive outcomes for both the person with dementia and their care partners. There are many opportunities for a person living with dementia to be supported to engage or re-engage in leisure activities. If you're able to first identify what the specific challenges might be for you, a range of strategies could be devised to assist in addressing these. For example, if you find it difficult to start an activity, you might need someone to help you start. A family member could set out the task materials first and then suggest you do the activity. Sometimes actually seeing the materials set out for an activity makes it a bit easier to get involved. And I just have to say that I enjoy cooking as an enjoyable activity, so these slides might be a bit biased towards cooking leisure activities. I was one of those sourdough people during the lockdown. Okay. If you find it difficult to remember the steps of an activity or read instructions like you used to, for example, following a recipe, there are things that your supporters could do to try and assist. For example, if you enjoyed cooking, a step-by-step recipe with pictures rather than words might help. Or having a family member or supporter provide verbal prompts to help you remember what you need to do next might be useful. Sometimes continuing to engage in complex activities like a crossword may be too demanding, but simplifying the activity, for example, doing a find a word, may help you to be able to continue doing an activity that's very similar to your interests. Sometimes family members and care partners may have difficulty working out how they can support active engagement in leisure activities. So, for example, they may have the best intentions, but as Kate mentioned earlier, if they don't understand what abilities the person with dementia still has, they may unintentionally limit the opportunities for the person to participate. And while dementia will invariably impact on a person's ability to participate, there are ways that we can assist the person to engage in activities using their intact abilities. Understanding around what the person's current abilities are will help to identify activities that fit within their skills. And when thinking about the person's current abilities, we need to consider a few factors: their physical abilities, their cognitive or thinking abilities, the demands of the activity or how difficult it is, and the environment in which the activity will be done. In addition to understanding the person's abilities, having a knowledge of the person's habits can also be a strength. A person with dementia may retain their ability to do activities which they have habitually done for a long time, and these skills could be harnessed into engagement in different activities. So, for example, if Michael has always enjoyed unpacking and sorting the groceries, offering him other sorting activities using familiar items might catch his interest and provide an opportunity for him to succeed in another enjoyable activity. Family members can support a person with dementia to engage in activities using a range of strategies, such as activity setup. Dementia can make it difficult for someone to plan or imagine an activity, so setting out the activity materials for the person can assist with getting started. Activity simplification. Sometimes an activity in its original form can become difficult to complete. So family members can help by either simplifying the activity, like with the find a word example I provided earlier, or reducing the number of steps required to complete the activity. For example, for a person who always enjoyed doing the household grocery shopping, but was no longer able to manage all the planning steps, the family supporter could help by planning the meals with the person with dementia and writing a shopping list, and maybe the person with dementia could then still do the shopping part. Providing verbal or physical prompts if the person gets stuck during an activity may help a person to continue engaging in something enjoyable. For example, helping the person to continue through the steps of making a meal. However, another important strategy that family can do to help a person engage in an activity is to know when to stand back and just allow the person a bit more time to try and do something themselves. Finally, simplifying the environment is a really useful strategy that family members can do to assist a person to engage in an activity. A kitchen table covered in household items and laundry can make it difficult for a person with dementia to identify and concentrate on an activity set up on the same table. Creating a clear space with only the specific items laid out for the chosen activity can help a person with dementia to engage in that activity. A person's previous interests and hobbies, as well as their current hobbies, leisure interests, and abilities, form an important part of identifying appropriate leisure activities for each individual person. Identifying leisure pursuits starts with a conversation with the person with dementia and does often involve the family supporter as well when necessary. Sometimes people can find it difficult to think of leisure activities that they used to or currently enjoy. To help overcome this difficulty, researchers have developed a list of potential leisure activities that one might enjoy now or maybe they used to enjoy. It's called the Pleasant Event Schedule for Alzheimer's disease. But whether you use this tool or not, it's useful to brainstorm a range of activity ideas which you might enjoy. Participating in activity involves a range of factors, including the person's physical and cognitive abilities, their personal interests, the demands of the activity, such as the number of steps involved, and the activity environment. People with dementia can experience challenges in some of these areas, which may limit their ability to participate in leisure activity. Anecdotally, this is often viewed by family members as the person no longer wanting to do their previously enjoyed activities. However, it may just be that the person is no longer able to initiate or engage in the activity in its original form. Therefore, even if there's an activity that you used to enjoy, but you may find challenging now, add it to your brainstorming list. With a bit of creativity and support, it's possible you may be able to engage in the activity or something very similar in a way that matches your current abilities. So I just want to finish on a case study, which shows how a person can be supported to continue doing what they love, despite having some difficulty in doing that activity independently. Mr. Wong is 72 years old and lives with mild dementia. He lives with his wife, who is also in her 70s. Mr. Wong used to work as a market gardener and is really keen to work in his vegetable garden. He particularly enjoys watering the garden and pulling out weeds. Sometimes Mr. Wong forgets to pack away items he has used, such as the hose. And recently, Mr. Wong tripped on the hose and fell to the ground. He wasn't able to get up and his wife called an ambulance for assistance. And now when they're in the garden, Mrs. Wong provides standby assistance. Mrs. Wong really wants to support her husband to continue with gardening as she knows how important it is to him, but she's worried about him falling. Mrs Wong arranged for Mr Wong to receive a reablement or rehabilitation program through their local community aged care provider. The allied health team visited Mr and Mrs Wong and worked together with them to identify Mr Wong's goal for the reablement program. The goal was to identify and trial the most appropriate aids for Mr Wong so that by the end of the 8-week program, he would be able to effectively use the aids in the garden with some verbal prompting from his wife to reduce his chance of falling while watering the plants and doing the weeding. The reablement program would involve a multidisciplinary team working together to help Mr Wong achieve his goal. The occupational therapist assists Mr Wong's outdoor mobility, his ability to use different aids, and help to identify the most appropriate garden aids to support Mr Wong's continued participation in gardening, such as a raised garden bed and a retractable hose to reduce the chance of tripping over it. The occupational therapist also provided support in strategies for using these new aids and worked with Mrs Wong to develop appropriate communication and activity support strategies. The physiotherapist assessed Mr Wong's balance and strength and provided an appropriate mobility aid to use when outside in the garden. And the physiotherapist also helped Mr and Mrs Wong to learn strategies for getting up if he were to have a fall. And finally, the exercise physiologist provided specific exercises to support Mr Wong's engagement in his preferred activity of gardening. For example, to bend over in order to weed, to carry a hose, and to increase his chances of getting up if he were to have a fall. So the exercise physiologist planned an exercise program for Mr Wong involving lower limb exercises, including balance and strength to support bending, core-related exercises to support leaning forwards in the garden, and arm strength to support the use of the selected aids. Throughout this reablement program, Mr Wong felt really supported to continue doing what he wanted to do, and Mrs Wong felt much more confident in how best to support him in this activity as well. Thank you so much for the opportunity to talk to you all today.